Ever feel like when you're trying to learn about something super important like pain management,
Hmm.
there's just way too much information out there?
Yeah, it can be overwhelming for sure.
So that's what we're tackling in this deep dive today. We've got a ton of sources all about analgesics and pain control, and we're going to break it all down for you.
Absolutely.
We want you to really get how pain works, like in your body, and all the different ways we can deal with it, both with meds and without them.
Exactly. Think of this as like your guide to the world of pain relief. We're going to like trace the path of a pain signal, see how it gets from like ouch to your brain, and then look at all the ways we can stop it along the way.
So first, let's talk about the different types of pain, right? Because it's not all the same. We've
Yeah.
got acute pain, which is like that short, intense burst of pain, like stubbing your toe.
Yeah, yeah.
And then there's chronic pain, which sticks around for a lot longer, more than 6 months, really gets in the way of your life.
Yeah, that's the kind that could really wear you down.
It's kind of like the difference between like a sudden thunderstorm and just constant drizzle, right?
Yeah, I like that. That's a good way to put it.
But then when we look even closer, our sources actually categorize pain by its cause or origin,
All right. So first you've got nociceptive pain.
which is,
That's the one that's triggered by actual tissue damage.
okay, so like an injury.
Exactly. And even within nociceptive pain, you've got two subtypes.
Okay.
You've got somatic pain.
Yes.
That's like the sharp, very localized pain, like a
Yep.
bee sting.
Oh, yeah.
And then there's visceral pain, which is usually more of a dull, throbbing ache, like when you have indigestion.
Oh, okay. So like a stomach ache.
Yeah, exactly.
Interesting how they feel so different, even though they both come from tissue damage.
Right. And then we've got neuropathic pain, and this is where things get really interesting.
Okay, tell me more about neuropathic pain.
This one comes from damage to the actual nerves themselves.
Oh, wow.
Yeah, and it can cause burning, shooting pain, or even numbness. People often describe it as feeling like electric.
Electric, wow.
Yeah, and what's important is that because it comes from the nervous system itself, it often doesn't respond to the same treatments as nociceptive pain.
Oh, so you really have to know what kind of pain you're dealing with.
Absolutely. Diagnosis is key.
Okay, so let's actually go back to the beginning. Like, how does a pain signal even get from, say, my hand to my brain?
Right, so it all starts with these things called nociceptors. They're
Mm.
like little sensory nerve endings that basically act as alarm systems, detecting any potentially harmful stuff.
So if I touch a hot stove, those are the things going off.
Exactly. They're like, hey, danger.
Okay, and then what?
So then the signal travels up to the spinal cord via these nerve fibers. Think of them like lanes on a highway.
Okay.
You've got the A delta fibers. Those are like the express lane. They carry that sharp initial pain, the immediate ouch.
Gotcha.
And then you've got the C fibers. They're a bit slower. They carry the dull, achy pain that kind of lingers.
Oh, so it's like if you touch a hot pan, the A delta fibers are why you immediately pull your hand away. And then the C fibers are that sore throbbing you feel afterwards.
You got it.
Makes sense.
So then, where the nerve fibers meet the spinal cord, this chemical messenger, substance P, jumps in. It's like the relay runner, passing the pain message on to the next set of nerve cells.
So substance P is kind of like the middleman.
You could say that. It's the one saying, hey, brain, we've got a problem down here.
Wow. But thankfully, our bodies aren't just sitting there taking the pain, right?
Of course not. We've got our own built-in pain management system.
Our bodies are so cool.
Right. So these are our endogenous opioids, things like endorphins and caffeine.
Oh, yeah. Endorphins, like the runner's high thing.
Exactly. There are natural painkillers. They can actually block the transmission of pain signals.
So they're like, hey, substance P, hold up. We're good here. You can chill out.
Pretty much.
Yeah.
It's like our body has its own volume control for pain.
I love that analogy.
So it's not just about sending pain signals, it's about controlling them too.
So it seems like in this whole process, from the nociceptors going off to the signals traveling to the brain, there are a lot of points where we can actually intervene and try to manage the pain.
Exactly. That's where all the different pain management strategies come in.
So let's talk about those.
Okay.
Let's start with the non-drug methods.
Sounds good.
Our sources really emphasize how important these can be, not only for mild pain, but also in conjunction with medication.
Yeah, they can really work together to help reduce the dose of medication you need and minimize side effects.
So it's like a team effort.
Exactly. And the cool thing is there are so many different non-pharmacological methods out there.
Like,
Well, you've got the classics like acupuncture, massage, heat, or cold therapy.
yeah, those are pretty well known.
Right. But then you've also got things like meditation, relaxation techniques, art and music therapy, even guided imagery, where you use your imagination to help manage the pain.
Oh, wow, I haven't heard of that one.
It can be surprisingly effective for some people. And there's more. Chiropractic intervention, hypnosis, physical therapy, therapeutic touch, TNS units, those little devices that send electrical pulses to the skin, and even topical warming agents you can apply directly to the area.
Wow, that's a lot of options.
Right. And if we're talking about interventions by a medical professional, there's also nerve blocks, where they inject local anesthetic to target specific nerves and block pain signals.
So many tools in the toolkit.
It's pretty impressive, right? And it's fascinating to think about how each of these methods might actually be working on a different level to modulate pain perception.
What do you mean?
Well, some of them, like acupuncture, might actually stimulate the release of those endogenous opioids we talked about,
Oh, interesting.
while others might be more about distracting the brain from the pain signals, reducing muscle tension, or even changing how the nervous system processes those signals.
So it's not just about masking the pain. It's about actually changing how your body deals with it.
Exactly. It really shows how connected the mind and body are when it comes to pain.
Okay, so that's the non-drug side of things. Let's move on to medication now.
All right.
Our sources break this down into two main categories: opioids and non-opioids.
Right. Opioids are basically substances, either natural or synthetic, that act like morphine. They're typically used for more severe pain,
Okay.
and they work by being agonists, meaning they bind to and activate specific receptors in the brain and spinal cord,
Mhm.
mainly the mu and kappa receptors.
Well, it's like a key fitting into a lock.
Exactly. And that triggers the pain relief.
Gotcha. And you mentioned before that there are also opioid antagonists.
Right. Those do the opposite. They block those receptors.
Okay, we'll come back to those.
Yeah.
But first, let's talk about an example of an opioid agonist: morphine.
Okay, so morphine is a powerful painkiller, but it also has other effects on the body. It can cause euphoria, constricted pupils, and it can even stimulate the heart muscle a bit.
Wow, that's a lot going on.
Yeah, and it's important to remember it has some potentially serious side effects too. Well, it can cause respiratory depression, which means your breathing slows down and becomes shallow.
That sounds scary.
It can also cause sedation, nausea, vomiting, a feeling of unease or dissatisfaction called dysphoria, even hallucinations. It can make you dizzy, itchy.
It seems like a drug with a lot of potential benefits, but also some serious risks.
Absolutely. And there's a black box warning on morphine too.
Which means?
It means there's a potentially fatal risk of respiratory depression if it's mixed with alcohol, certain types of antidepressants like MAOIs and TCAs, or other sedative medications. Oh, and with general anesthetics too.
Wow, so there are a lot of things to be careful about with morphine.
Yeah, definitely not a drug to be taken lightly. It's also not recommended for people with asthma, any kind of blockage in the GI tract, or severe liver or kidney problems.
Okay, so morphine is definitely a drug that needs to be carefully considered and monitored.
Absolutely. From a nursing perspective, it's important to remember that morphine is a Schedule II controlled substance.
Which means?
It means it has a high potential for abuse and dependence. So we have to monitor patients very closely for things like orthostatic hypotension.
Which is?
It's a sudden drop in blood pressure when you stand up.
Yep.
Can make you feel dizzy, lightheaded, maybe even faint.
Oh, yeah.
And in terms of pregnancy, it's considered Category B, but can be Category D if it's used for a long time or in high doses near the end of pregnancy.
Gotcha.
And crucially, if someone overdoses on morphine, the antidote is naloxone, which is also known as Narcan.
Narcan. Okay, so let's actually talk about that now.
Sure.
Naloxone is a prime example of an opioid antagonist, right? The opposite of morphine.
Exactly. Its main job is to reverse the effects of opioids, especially that respiratory depression we talked about. Basically, it kicks the opioid off those receptors in the brain and spinal cord.
So it's like a reset button.
Pretty much. It can also be used to diagnose an opioid overdose, and sometimes even to help with low blood pressure in cases of septic shock.
So it's a pretty versatile drug.
Yeah, it's a really important tool for dealing with opioid-related emergencies.
But like any drug, it has potential side effects, right?
Of course. It can cause a sudden spike in blood pressure, tremors, hyperventilation, nausea, vomiting, even drowsiness. And there are some situations where you wouldn't use it. Like if the respiratory depression is caused by something other than opioids. And you got to be careful with people who have liver problems.
Okay.
Oh, and another interesting thing, you're not supposed to use it with echinacea.
Echinacea, like the herbal supplement.
Yeah, it's a weird interaction, not fully understood, but something to be aware of.
Wow, who knew?
So in a hospital setting, we usually give naloxone if someone's breathing rate drops below 10 breaths per minute.
Oh, wow.
And Because its effects can sometimes wear off before the opioid is fully out of the system, we always have to have resuscitation equipment ready, just in case the breathing problems come back.
So it's like a constant watch.
Yeah, you got to be on your toes.
And what about a naloxone overdose?
Well, thankfully, it's pretty rare. But if it does happen, treatment is usually supportive. Things like oxygen, IV fluids, maybe medications to raise blood pressure if needed.
Okay, good to know.
And of course, naloxone is a pregnancy Category B drug.
Gotcha. So one of the big concerns with opioids is the potential for dependence.
Definitely. Our sources talk about both physical and psychological
And
dependence.
what's the difference?
Well, physical dependence is when your body gets used to having the opioid around all the time.
Okay.
So if you suddenly stop taking it, you can go through withdrawal, which can be pretty rough.
Yeah, I've heard about that.
Psychological dependence is more about craving the drug, wanting it not just for pain relief, but also for its other effects.
So it's like an addiction.
Exactly. And you can have both types of dependence at the same time.
So how do you treat opioid dependence?
Well, one common approach is to switch the person from stronger opioids to a longer-acting oral medication, like methadone. And it's important to understand this isn't a cure. It's about managing the dependence, preventing those awful withdrawal symptoms, and reducing the cravings.
So it's a long-term process.
Definitely, often months or even years.
Oh, that's a long
It
time.
really shows how serious opioid dependence can be. And it underlines how important it is to assess the risk before even starting someone on opioids, and to always have naloxone on hand, just in case.
Makes sense.
So moving on from opioids, let's look at the non-opioid pain relievers.
Okay.
These are usually the go-to for fever, inflammation, and mild to moderate pain.
So like the everyday stuff.
Exactly. And a classic example is aspirin.
Aspirin, okay. I know that one.
Yeah, aspirin is actually pretty interesting. It relieves pain and reduces inflammation, but it's also used in low doses to prevent blood clots after a heart attack or stroke.
Oh, wow. I didn't know that.
Yeah, it's got a lot of uses.
But it also has side effects, right?
Of course. The most common ones are gastrointestinal problems like heartburn or even stomach ulcers. It can also affect your blood clotting, making you bleed more easily.
So are there situations where you shouldn't take aspirin?
Absolutely. You shouldn't take it if you're already on blood thinners, steroids, or other NSAIDs.
NSAIDs, those are.
Non-steroidal anti-inflammatory drugs like ibuprofen or naproxen.
Oh, right. Gotcha.
And mixing aspirin with alcohol is a big no-no. It can really irritate your stomach.
Okay, noted. Anything else to be aware of with aspirin?
Well, from a nursing perspective, we know that aspirin can increase the effects of some diabetes medications.
So people with diabetes need to be extra careful.
Absolutely. We also usually stop aspirin a week before any surgery because of that bleeding risk.
Makes sense.
Oh, and this is interesting. Aspirin can actually lower your cholesterol and potassium levels, and it can even mess with some pregnancy tests.
Wow, I had no idea.
And it's a pregnancy Category D drug, so definitely not safe for pregnant women.
Gotcha. And what about an overdose?
Well, for aspirin overdose, treatment usually involves giving activated charcoal to absorb the drug, maybe doing a stomach pump, and sometimes giving laxatives to help get it out of the system.
Okay, so definitely not something to mess around with.
Right. So next up, we have the NSAIDs. Those are the ibuprofen and naproxen we mentioned earlier.
Oh, right. Those are in pretty much everyone's medicine cabinet.
Exactly. They're great for mild to moderate pain and inflammation.
And side effects?
The most common ones are stomach upset, loss of appetite, headache, drowsiness, and in some cases, they can actually damage the kidneys, especially if you use them for a long time.
So it's always best to talk to your doctor before taking any medication, even over-the-counter ones.
Absolutely. Now, there's also a special type of NSAID called COX-2 inhibitors.
COX-2 inhibitor?
Yeah, they were developed to try to reduce those stomach problems we talked about.
Oh, so they're easier on the stomach.
That was the idea. An example is celecoxib. But even though they're supposed to be gentler on the stomach, they can still cause side effects. Things like abdominal pain, dizziness, headache, sinusitis, and sometimes allergic reactions.
So there's always a trade-off.
It seems like it. Then finally, we had the centrally acting analgesics.
What are those?
Think acetaminophen.
Tylenol, right.
Exactly. It's another super common over-the-counter drug.
And what does it do?
Mainly reduces fever and relieves mild to moderate pain. And the interesting thing is it actually works on the hypothalamus, the part of your brain that regulates body temperature.
Oh, so that's how it brings down a fever.
Yeah, it basically tells your body to cool down.
Clever.
So side effects from acetaminophen can include low blood pressure, dry mouth, constipation, drowsiness, and headache. And while it's generally safe at normal doses, you got to be careful not to take too much.
Especially with alcohol, right?
Exactly. That can really damage your liver.
Okay, good to know.
So shifting gears a bit, let's talk about the nursing process and pain management.
Okay, what does that involve?
Well, it's basically a systematic approach to caring for patients who are in pain.
Makes sense.
And it all starts with a thorough assessment.
Like a detective.
Kinda. We have to gather all the clues.
So what kind of things are you looking for?
Well, first, we want to know if the patient has any allergies, bleeding disorders, stomach ulcers, or liver or kidney problems,
Okay.
and if they're pregnant or breastfeeding. We also look at their breathing, their alcohol use, and of course, we need to understand their pain.
What do you mean by that?
Like, where is the pain? How bad is it? What does it feel like? What makes it better or worse?
Okay, so painting a full picture of the pain.
Exactly. And then we dig even deeper, looking at their medical history.
Like what?
Any heart problems, neurological issues, lung problems, liver, kidney, gallbladder, urological problems, history of cancer, any recent surgeries or injuries.
Wow, that's a lot of information.
Yeah, we got to be thorough.
Okay, so you gather all this information, and then what?
Then we can make a nursing diagnosis. Like maybe the patient needs more education about pain management. Or maybe they're at risk of becoming dependent on painkillers.
Okay, so you're identifying the problem.
Exactly. And then comes the planning stage.
What happens there?
We set goals for the patient's pain management. The main goal is usually to get their pain under control without causing any bad side effects or dependence.
Makes sense.
Then we put the plan into action. This is the implementation phase.
So this is where you give the medications.
That's part of it, but it's also about teaching the patient about their meds, any potential side effects, and those non-drug strategies we talked about earlier.
Okay, so it's a holistic approach.
Absolutely.
Yeah.
And the final step is evaluation.
So you're checking to see if the plan is working.
Exactly. We reassess their pain, check for side effects, look for any signs of dependence, and we also make sure the patient understands their treatment plan and how to take their meds properly.
So it's a continuous process.
It is. Pain management is definitely not one size fits all.
Okay, so our sources also talk about drugs specifically for headaches and migraines.
Right. Those are a whole other ball game.
They make a distinction between tension headaches, which are more common and usually go away on their own,
Yeah, those are the ones most people get.
and migraines, which are often more severe.
Migraines can be really debilitating. They cause this throbbing, pulsating pain, and some people get an aura beforehand.
An aura?
Yeah, it's like a warning sign. Some people see flashing lights or have other sensory disturbances.
Wow, that's crazy.
And migraines are often accompanied by nausea and vomiting, and certain things can trigger them, like certain foods or stress.
Okay, so different types of headaches require different treatments.
Exactly. For migraines, the main goals are to stop the pain during an attack and then try to prevent future attacks.
Okay.
And nurses play a big role in migraine management. We take a detailed history of the person's headaches, try to figure out what triggers them, assess their stress levels, and do a neurological exam to make sure there's nothing more serious going on.
So it's kind of like detective work again.
Pretty much. And during a migraine attack, we try to create a calm environment for the person. Maybe use cold packs and monitor them for any side effects from their medication.
One drug they mention for treating acute migraines is sumatriptan.
Oh yeah, sumatriptan, also known as imitrexatriptan.
What's a triptan?
They're a class of drugs that work by constricting blood vessels in the brain, which we think are dilated during a migraine.
So it's like squeezing those blood vessels back down to normal.
Exactly.
And side effects.
The most common ones are upset stomach, dizziness, drowsiness, and a feeling of warmth or flushing.
Okay. Are there any contraindications?
Yeah, a bunch. You wouldn't use it if someone has recently had a heart attack, has angina, uncontrolled high blood pressure, diabetes, or serious kidney or liver problems.
Okay, so lots of things to consider.
Yeah, you also have to be careful if they're taking certain antidepressants like MAOIs or SSRIs, and you definitely don't want to mix it with St. John's wort, echinacea, or ginseng.
Wow, there are a lot of interactions.
Right, so from a nursing perspective, we monitor the patient closely for any changes in their level of consciousness, any signs of seizures,
Okay.
and because the first dose can sometimes cause heart problems, we always have resuscitation equipment ready, just in case.
Always better to be safe than sorry.
Absolutely. And sumatriptan is a pregnancy category C drug, so there's some risk there.
Gotcha. And what if someone overdoses?
An overdose on sumatriptan can cause weakness, lack of coordination, watery eyes and mouth, tremors, seizures, or breathing problems.
Sounds scary.
Yeah, it's serious. But thankfully, it's pretty rare.
Okay, so for people who get migraines a lot, there are medications to try to prevent them, right?
Right. Those are called prophylactic medications.
And how do they work?
They work in different ways, but the goal is to reduce the frequency and severity of migraines.
Okay.
Some examples are anticonvulsants like topiramate, beta blockers like anenolol, calcium channel blockers like nifedipine, and even some antidepressants like amitriptyline.
So drugs that were originally meant for other things can be helpful for migraines too.
Exactly.
That's interesting.
Yeah, it is. But no matter what medication you're using for headaches or migraines, it's super important to do a good assessment beforehand.
Like what?
Well, we need to know their full medical history, especially if they have any heart, neurological, liver, or kidney problems.
Okay.
And if they're pregnant or breastfeeding, we need to know all their medications, even over-the-counter ones. And if they use caffeine, nicotine, or alcohol.
Gotcha.
And of course, we check their vital signs, their weight, their pulse, their level of consciousness, how much pain they're in, and what treatments they've tried before.
So basically everything.
Pretty much.
Okay, our sources also cover anesthetics.
Ah, yes, the stuff that makes you numb.
So what are anesthetics exactly?
They're drugs that block sensation, either in a specific part of the body or throughout the whole body.
Okay.
And they distinguish between local anesthesia, which numbs a small area while you stay awake, and general anesthesia, which makes you completely unconscious.
So you don't feel anything.
Exactly.
So tell me more about local anesthesia.
Well, there are different types depending on how it's given and how much area you need to numb.
Okay.
So you've got topical anesthetics. Those are creams, sprays, suppositories, drops, lozenges. You put those right on the skin or mucous membranes.
Okay.
Then there's infiltration anesthesia, sometimes called a field block.
Oh, what's that?
It's where they inject the anesthetic right into the tissues around the area they're going to work on.
Oh, okay.
Then you've got nerve blocks.
What are those?
It's where they inject the anesthetic near a nerve that supplies a larger area so they can numb a whole limb or part of your face.
Wow, that's pretty powerful.
Yeah, it is. And then there's spinal anesthesia.
Spinal. That sounds intense.
It is. They inject the anesthetic right into the cerebrospinal fluid in your lower back. It numbs your lower abdomen, legs, and perineum.
Oh, wow.
Yeah. And lastly, there's epidural anesthesia.
That's the one they use for labor, right?
Exactly. It's very similar to spinal anesthesia, but they inject the anesthetic into the epidural space, which is just outside the membrane that surrounds the spinal cord.
Okay, so lots of different ways to deliver local anesthesia.
Right. And they all work in pretty much the same way.
How's that?
They block sodium channels in the nerve cells.
Sodium channels.
Yeah, they're these tiny pathways that allow sodium to flow in and out of the cells.
Okay.
And by blocking them, local anesthetics stop those nerve impulses from reaching the brain.
So you don't feel the pain?
Exactly.
But there are still side effects, right?
Of course. Early on, you might see stimulation of the cardiovascular and central nervous systems,
What does that look like?
maybe some anxiety, tremors, that kind of thing.
Okay.
And later on, you can see CNS depression, like drowsiness, maybe even seizures.
So it's a balancing act.
It is. And local anesthetics are divided into two main groups, esters and amides.
Okay, what are those?
Esters were the first ones they came up with. Examples are procaine, also known as novocaine, and benzocaine, which is in stuff like Solarcaine.
Okay.
But they're not used as much anymore because they don't last as long and they cause more allergic reactions.
Makes sense.
Side effects from esters can include CNS depression and local reactions like burning, stinging, redness. And in rare cases, they can even cause serious stuff like respiratory arrest, circulatory failure, or anaphylaxis.
Anaphylaxis, that's like a severe allergic reaction, right?
Exactly. Now, amides are the ones that are more commonly used now.
Like,
And the most common one is lidocaine, also known as xylocaine.
okay,
They last longer and cause fewer side effects than esters,
that's good.
but they can still cause local irritation, and rarely things like difficulty breathing, convulsions, respiratory depression, anaphylaxis, and contact dermatitis.
So you always have to be careful.
Definitely. And if someone overdoses on an amide local anesthetic, we can treat them with something called lipid rescue. It's an IV treatment that helps to bind the anesthetic in the blood and reduce its toxicity.
Wow, that's pretty cool.
It is. And from a nursing perspective, we know to avoid putting local anesthetics on large or broken areas of skin, and we never put it in the eyes.
Okay, makes sense.
And lidocaine is a pregnancy category B drug.
Gotcha.
And there are some situations where you wouldn't use local anesthetics at all.
Yeah.
Well, if someone has a severe injury, sepsis, certain blood disorders, problems with their heart rhythm, or a severe heart block.
So it's all about weighing the risks and benefits.
Absolutely. And just like with any other medication, we do a thorough assessment before giving a local anesthetic.
So what does that involve?
We look at their medical history, especially any heart, liver, kidney, lung, or neurological problems.
Hmm.
We also check if they're pregnant or breastfeeding, and we get a full list of their medications, including anything over the counter.
Oh.
We also check their vital signs, their weight, and we carefully examine their skin, where the injection is going to be, making sure there are no cuts, scrapes, or burns.
Gotcha.
And we might do some blood tests, like a CBC, electrolytes, and liver and kidney function tests.
Okay, so basically you're checking everything.
Pretty much. We want to make sure it's safe for them to have the anesthetic.
Okay, let's move on to general anesthesia.
All right.
So how does general anesthesia work?
It's pretty complex, but basically it blocks sodium from flowing into the neurons in your brain.
Okay.
And that slows down nerve impulses and reduces brain activity, which makes you unconscious and unable to feel pain.
So it's like hitting the off switch for your brain.
In a way, yeah.
I've heard that general anesthesia has different stages.
You're right. There are 4 stages. The first stage is where you lose pain sensation.
Okay.
Then comes the excitement stage, where people can get a bit agitated or restless.
Oh, that sounds fun.
Not really. That's why we try to get them through that stage quickly.
Makes sense.
Then comes surgical anesthesia, where the muscles are relaxed and the reflexes are gone. That's when they can do the surgery.
Okay.
And then the final stage is where the breathing and heart stop.
Oh, wow, that's not good.
No, that's the danger zone. We never want to get to that stage.
Okay, so you stay far, far away from stage 4.
Absolutely. Now, there are different types of general anesthetics. Well, you've got intravenous anesthetics, which are given through an IV and work very quickly.
Okay.
They're often used in combination with inhaled anesthetics, which provide more complete anesthesia and muscle relaxation. Host speaker.